In this fifth and final part of our Psychopharmacology 001, we're going to look at two major disorders of mental health: attention deficit across the lifespan and also dementias. Then we will give a very brief consideration of sleep aids. The incidence in the number of cases reported for attention deficit has exploded in the past 10 or 15 years, and the reasons for that may be many. About 5% of the U.S. population of children are diagnosed with attention deficit. We used to think that this was just an issue for children. However, we are finding that about half the children diagnosed with attention deficit continue to have difficulties as they grow into adulthood, and some of them have never been treated, even though they did definitely have symptoms of attention deficit issues in their childhood. We'll be discussing all of this in much more detail when we get to these issues in MSN 635. What you need to know for now is that the primary symptoms of attention deficit are that of inattention and that of impulsivity. The characteristic of hyperactivity is being called into question by some, that maybe hyperactivity is just part of the developing brain of childhood. Whether we say it's inattention, hyperactivity, and impulsivity, or just inattention and impulsivity, kind of debatable. However, what is not debatable is that the primary consequences are that of poor performance, whether it be children in school or adults at work, impaired social skills because of the impulsivity, the blurting out, the lack of attention, where those around the one suffering begin to blame the person for their problems and what's wrong with you, and these people don't pick up on the social cues, and so there's a lot of damaged self-esteem. There are four brain regions that are primarily associated with the problems of attention deficit. The dorsolateral prefrontal cortex is implicated in our ability to sustain attention, to make good decisions. The anterior cingulate cortex is involved in the ability to selectively pay attention and also to some of the inattentive symptoms. The prefrontal motor cortex is involved in all of the activity, the hyperactive symptoms, and finally the orbital frontal cortex is involved in the problems of impulsivity. I see it, I want it, I go for it, and there is no connection to the dorsolateral prefrontal cortex, where I should maybe stop and think about this a bit. In this slide, if you're watching it in the slideshow presentation, you will see it develop progressively. But at the top, what we have are an artistic representation of a pyramidal neuron in each of the major areas of the brain, and then flowing down from the orbital frontal cortex. Again, if you fold your fingers over your thumb, the orbital frontal cortex are kind of like your fingernails up to your first knuckle, and you'll see that they are also touching into the limbic system. So also notice the little projections off of those iconic pyramidal cells at the top. In the orbital frontal area, they're connected, the neurons are connected into the limbic area, which causes the impulsivity of interrupting and blurting out and not waiting turn, and the motor symptoms of being unable to sit in the seat and stay still, hyperactivity. And then moving over to the right, the dorsolateral prefrontal cortex and the anterior cingulate are involved in our cognitive issues of not being able to organize, not being able to sustain effort, and not being able to retain because we are not listening well. We can't focus in. Attention deficit disorder really is one of the major success stories we have in psychiatry, mental health, that if treated with the medications we'll be looking at in a couple of minutes, it can really be resolved quite effectively. And if it is not treated, unfortunately, the problems can progress and become even more severe in a person's life and for the person in society. So we have one more iconic representation of a pyramidal neuron, and it is in the ventral medial prefrontal cortex area going into the limbic connections into the limbic area that have all these problems of behavioral issues that then later can become diagnosed with an official diagnosis such as conduct disorder, bipolarity, anxiety spectrum, oppositional defiant disorder. Therefore, the younger we can begin to detect and treat, maybe the better will be the outcomes for both the individual and society at large. I like to compare attention deficit disorder to a shortwave ham radio, where you have a signal coming in, but it's very weak. And so you keep turning the dial, trying to hone in on the signal. You also have a lot of static coming in, and so you're turning the dial, trying to filter out that static. And that is primarily what is going on with attention deficit disorder. There are two neurotransmitters that are primarily implicated in the problems. Norepinephrine is the neurotransmitter in the prefrontal cortex and the other areas that we mentioned that helps us to hone in on the signal to make it strong so that it comes through and we know what to pay attention to because we're getting a good, strong signal. Dopamine is the neurotransmitter that helps us filter out all that static. And so dopamine filters out all the other impulses and stimuli that keep distracting us and keep us from focusing on what we need to do. And so here we have in this big representation, we have the LC, which is on the far right, and we know that stands for the locus coeruleus, and that is the one that dispenses or secretes norepinephrine. And when norepinephrine is secreted, we get a signal that is increased. Down at the bottom, it's increased. And on the left-hand side of this icon, the VTA, the ventral tegmentum area where dopamine is secreted, and if that is produced in good numbers in the synapses, the noise levels are reduced. And so a person is able to focus in on the signal and able to filter out the distractions. They are now attentive, and they are now able to sustain attention. This slide helps us to understand why there has been quite an increase in the number of adults who are now being treated for attention deficit disorder. Generally, children are the ones in whom attention deficit is first noticed and diagnosed, and they get treated, and they're fine because now they're able to pay attention, they're able to control their impulses, and so they don't get into all those other problems that you saw in previous slides, and they don't progress into anxiety disorders and mood disorders and alcohol, stimulant, substance abuse. Hopefully, not guaranteed, but hopefully. All right. However, if a person has not been treated in childhood, then they are going to get into those problems and they're going to come into mental health and be treated first possibly for alcohol and stimulant substance abuse, and then for depression, bipolar disorders, etc., and then for anxiety disorders. And finally, when all of that has been peeled away, and son of a gun, there are still problems with attention, we treat adult attention deficit disorder. We classify the medications for attention deficit as stimulants and non-stimulants. And the word stimulant may be a bit misleading. If we have parents who bring their child in for treatment for attention deficit and we tell them we're going to prescribe a stimulant for their child, they may look at us like we are crazy. This child is already overactive, he is blurting out, what the heck are you doing giving my child a stimulant? That's going to make it worse. Remember that the attention deficit medications, what they do is they affect the presence of norepinephrine to hone in on the signal and dopamine to filter out unnecessary signals. So they are stimulating the effectiveness of those neurotransmitters at the receptors. We break the medications are classified as D and L isomers, and that's a very complex chemical concept that I don't think we have to know all that much, except that they are like mirror images in terms of D and L. And again, we'll look at this more in depth when we get into MSN 635. The D and the L isomers are each equally potent on the norepinephrine transporters, but the D isomer is more potent in action on both the dopamine and the norepinephrine transporters. So we have two major groups of stimulants. We have the methylphenidate group, which has a lot of brand names to it, that is both come in D and DL formulas. And then we have amphetamine salts, dextroamphetamines, and also they come in D and DL formulations. We'll look at that in the next slide. On page 53 of the Preston and Johnson text, there is a list of the medications used to treat attention deficit by generic brand and dosing. We have many formats for the two basic classes, the amphetamines and the methylphenidates. They come in very, very different names because we have them as patches, we have them as liquids, we have them as chewable tablets now as well. But basically they are either an amphetamine formulation or a methylphenidate formulation, and they are either a D or a DL, and they can be immediate release or extended release. There is yet a newer medication supposedly called Vyvanse. It is still generic brand only. Lisdexamfetamine. It is an amphetamine, but what happens is it has to be taken ingested into the stomach, and then there is a lysine molecule attached to the dextroamphetamine molecule, and in the stomach the lysine molecule gets taken off, and the dextroamphetamine molecule becomes then active and effective, absorbed into the body, and increasing the presence or stimulating the function of the receptors of norepinephrine and dopamine. And then modafinil is one that I have never had to use, Provigil, for those who have narcolepsy. In addition to the stimulant amphetamine or methylphenidate medications, we also have some that are non-stimulants to treat attention deficit. If norepinephrine and the receptors of norepinephrine are major culprits in the problems associated with attention deficit, it stands to reason that if we can use a norepinephrine reuptake inhibitor, we may improve the person's ability to focus. So Strattera or atomoxetine is a non-stimulant that works on both norepinephrine and dopamine. And bupropion Wellbutrin for depression is also one that works on norepinephrine. So these might be first-line approaches, especially if we're treating adults in whom there may have been some substance abuse issues in the past that raise concerns for us about re-triggering or relapsing into addictions. Also, alpha-2 adrenergic agents that work on the adrenergic receptors involved with norepinephrine, guanfacine, called Intuniv or Tenex, and clonidine, which is actually a blood pressure medication, as you already know, but it is used because it works on the norepinephrine systems in the brain. There is a chart that I will try and make available to you from one of my favorite psychiatry mental health resources, Daniel Carlott, called the Psychiatry Report. While these medications may be our most effective medications, so to speak, our best success stories, they also do have side effects, and especially in children. There can be an increased irritability, there can be a delayed growth, there can be appetite suppression with nausea and upset stomach. Generally, that's why we do the weight and height on children who are on these medications. Studies have shown that even if there is some suppression of growth rate, that eventually the child does catch up and is in normal ranges. We counsel that people take these medications primarily in the morning or early afternoon if they need a second dose, because if it's taken too late in the day, it can interfere with sleep. There are some possible problems with cardiac, with tachycardia, hypertension, and it is not necessary to do a baseline EKG on all children, but it is necessary that we do a thorough exploration assessment in their family and personal history to find out if there is any history of cardiac issues. If there are histories of problems within the child, him or herself, or in the family, then the American Association of Child and Adolescent Psychiatry recommends that an EKG be done prior to starting the medication. Sudden death is extremely rare, and so is psychosis, but we have to at least be aware that that's a possibility. And again, we monitor for height and weight of children at each session, not adults. Now, adults can also have some of those side effects as well. There are varying theories about giving children what are called medication or drug holidays on weekends and during the summer. That is a possibility, but they are still going to be at home and they're still going to be with peers, and so they may still be having problems with interpersonal relationships because of their behaviors with attention deficit. The recommendation is that for adults, absolutely no holidays. Adults have adult responsibilities. They are, if they're parents 24/7. You do not want to be on a drug holiday. And finally, in treating adults, the recommendation is that you start with an extended release formula because it may cut down on the possibility of abuse. And the source of that abuse is that in the brain with the medication there is an influx of dopamine into the nucleus accumbens, and the nucleus accumbens is the area of the brain associated with addictions. We'll look at that again in more detail in MSN 635. We move on now to our second to the last group of medications that we'll be considering. The Preston Johnson book does not have anything on the medications for dementia. These also fall into the clan of cognitive enhancers, but actually it might be better to say that they are cognitive conservers because they do not improve memory. They only sustain what memory is still there as the progression of Alzheimer's or other dementias progresses. What happens with the dementias is that there is a progressive destruction of the neurons, especially the acetylcholine neurons in the brain, and also glutamate neurons are involved. So the medications that we use work on either one of two major systems. One, they work in the acetylcholine system, trying to maintain the presence of acetylcholine, and or they block the presence of glutamate through receptor blockages. Now, it's a rather complex understanding of the neurobiology, which we will look at more in depth in MSN 635. Also, you can find in Khan, Khan Academy. If you go to Khan Academy and search around, you will find a pretty good little presentation on the neurobiology of Alzheimer's disease. But there are two primary theories of what causes it. The first is what's called the amyloid cascade hypothesis. Amyloids are small little bits of protein, and because of either a genetic malfunction, the protein, which is both within the cell and outside the cell, does not get properly processed, and these plaques begin to accumulate, and once the plaques accumulate to a certain level, they interfere with the synaptic functions. When the synaptic functions have been disrupted, there is an inflammation process within the nervous system and the release of toxic cytokines. When that happens, these plaques continue to build up, and they interfere with what are called the microtubules or in the axon, which are like the small freight cars transporting information and nutrition back and forth from the cell soma into the axon, and those little like trolley trains get all tangled up, and eventually there is neuronal dysfunction and death. There is a theory that there is a mutation of the gene which breaks down those amyloid precursors, and they are the system of the APOE gene, and if someone has the allele of the APOE4 gene, they are more susceptible to developing Alzheimer dementia. And then glutamate, if it is the primary excitatory neurotransmitter in the brain, too much of it can lead to toxicity, infection, inflammation, and therefore, if we block the receptor, we would be blocking the presence of glutamate and decreasing the inflammatory process. As you already know, dementia is characterized by the decrease in memory. It also unfortunately progresses into loss of motor function to the point where the person can become pretty much incapacitated. There is a rapid progression from the actual diagnosis of Alzheimer's from mild into severe. The issue is that much earlier on, there has been a process taking place of the buildup of those amyloid precursor proteins and the development of those plaques that is preclinical or subclinical and not diagnosed. However, we do have medications that can help. They will slow the process, but they do not cure it, and we need to be very clear about that when we are educating people. Now, the two major medications that work on inhibiting acetylcholine esterase. Acetylcholine esterase is the enzyme that breaks down acetylcholine. Acetylcholine is the neurotransmitter most involved in, very highly involved in memory. So if acetylcholine is being broken down too quickly removed from the play field, then we're going to have problems with memory loss. If acetylcholine can be sustained, made more available on the play field, then we may at least slow down the progression of the disease. So Aricept, Donepezil, and Exelon patch, rivastigmine, both are acetylcholine esterase inhibitors. Then the next is Namenda, memantine, and it blocks the glutamate receptor, especially the N-methyl D-aspartate receptors, so that glutamate is less active in the system. Recently, in 2015, manufacturers came out with a combo pill of memantine and Donepezil, calling it Namzaric. The cost of these medications is pretty high. These cognitive enhancers or cognitive preservers do have a number of side effects. These medications are usually prescribed for at night, and this is therefore a focus that we need for our psychoeducation on the medications. Dizziness, headache, confusion, nausea, vomiting, diarrhea, loss of appetite, and very rarely seizures. Well, you can imagine you give this type of a medication to somebody in the evening who already has problems with memory, and now they have to use the bathroom, and they get up in the middle of the night, and then they're dizzy and they're confused, the possibility of falls, etc. So working with the family to say, okay, how can you create the most safe environment for your loved one, so that if they do need to get up to go to the bathroom in the middle of the night, there will not be further problems. Along with the memory and cognitive function issues that occur with Alzheimer and other dementias, there are further problems of agitation, irritation, mood disturbance, etc. And so we do use SSRIs and SNRIs, but we need to be careful to monitor for sodium-induced antidiuretic hormone problems. Also, we should avoid the TCA and the MAOIs because of their cardiac problems and the potential for hypertensive crises. Also for the agitation, we can use first generation. However, there is a form of dementia called Lewy body that is characterized primarily by hallucinations. We should, as a general rule, avoid the first generation antipsychotics in people who have the Lewy body form of dementias. So preferably the second generation of antipsychotics would be good. However, we need to avoid risperidone. It may possibly worsen the symptoms of Lewy body dementia. There is a black box warning against using antipsychotics to control the agitation that is associated with the dementias, and possibly the SSRI might be the better first-line approach, especially citalopram has shown some good results. We also use mood stabilizers such as gabapentin, probably in the adult geriatric population, avoiding Depakote because of the liver damage possibilities. And then be very, very careful of using sedatives, anxiolytics, and hypnotics in this population. There is a Beers list warning against using those types of medications. The difficulty we're finding now is that more and more people who have lived with psychosis spectrum disorders are entering into their geriatric years, and they're coming down with Alzheimer's. So we have somebody who is both schizophrenic and has dementia. They are being given the antipsychotic to treat the psychosis spectrum disorder, not because they were treating the agitation that might be associated with dementia. So these medications have to be used and considered on a case-by-case basis, and there has to be excellent conversation with, if possible, the client, him or herself, and definitely with the family to explain the risks and benefits. In topic 7 of MSN 634, we will be looking at the neurobiology of sleep and the medications used for sleep. I just throw this up here so you have some beginning awareness. Medications for sleep come primarily from the benzodiazepine family, and there is a so-called non-benzodiazepine. They still work on the GABA receptors, but in a slightly different way from the benzodiazepine sleep aids. Those are all listed there, and you can find the dose levels in your Stahl Prescriber's Guide. A newer medication that came out in 2015, working on a different function in the sleep-wake cycle neurobiology, is Belsomra, that inhibits orexin, which is a neurotransmitter involved in wakefulness. So if we inhibit it, hopefully we're producing sleepfulness. And melatonin is another hormone involved in the sleep-wake cycle. If we can enhance it through a medication called Rosarum or Ramelteon, we might be promoting better sleep. We also have several medications such as mirtazapine, quetiapine, and trazodone, which are used for depression, for mood disorders, for schizophrenic spectrum. However, a side effect of these medications is they produce a lot of sleepiness or promote sleepiness, so they're used off-label, taking advantage of a side effect of the medication. It's not their primary purpose. And we do need to be careful when using any medication that in an off-label way. Off-label means not approved by the FDA for that purpose. We need to also be documenting it very clearly. The difficulty with mirtazapine and quetiapine, even though they are very effective, they also can cause a lot of weight gain. And finally, antihistamines, diphenhydramine and hydroxyzine, Benadryl and Vistarol are both effective for promoting sleepiness because histamine is a primary transmitter in wakefulness. All of these different medications, and you can find a list of those in, well, not in Stahl, but you can find all of these medications in Stahl. All right, thank you. You have hung in there with me through this 5-part series of an intro peek at all those pills.